She was belted and her airbags were deployed. There are no passengers in her car, and the driver in the other car that she hit is en route to the ED in apparent stable condition via EMS. She denies any loss of consciousness and has no ongoing headaches. Just a little piece about clinical decision rules versus clinical assessment. So shouldn't our clinical assessment be good enough to determine who needs imaging and who could potentially have a C-spine injury? Well, apparently prior to the introduction of the Canadian C-spine rule, approximately 98% of imaging that physicians in the ED were ordering to rule out cervical spinal injury after blunt trauma were negative for fracture, and there are large variations in radiographic imaging between physicians. And in 2003, Bandiera published a study in the Annals of Emergency Medicine that compared the Canadian C-spine rule and unstructured clinical judgment for predicting clinically significant injuries. And they found that clinical judgment had a sensitivity of 92% versus 100% for the Canadian C-spine rule. You may think 92% is pretty good sensitivity, but if you consider the potential implications of missing an unstable cervical spine fracture, you want to be pretty sure that you're not going to miss them. So I think the high negative rate of radiographs were probably secondary to people being afraid of missing these potentially unstable fractures. So the Canadian C-spine rule was published in JAMA in 2001 by Steele and his colleagues. And I just wanted to go over the inclusion and exclusion criteria in some detail, because I think when you're using a clinical decision rule, it's very important to know who you can apply the rule to and who you can't. So in the study that Steele published, the inclusion criteria were neck pain from any traumatic mechanism, or no neck pain, but the patient had some visible injury above the clavicles, had not been ambulatory, and had sustained a dangerous mechanism of injury. So once you've determined that a patient doesn't have any high-risk features that mandate that you get radiography, then you move on to step 2, which is degrees left and 45 degrees right. Then their C-spine is cleared. I think it's just important to note that ability to rotate their neck is an active rotation, and it's regardless of pain. So the patient's allowed to have pain according to the C-spine rule. They just have to be able to get out to 45 in either direction. So let's go back to the case. I'm not going to summarize the whole thing because we just went over it, but 25 minutes ago, 60 kilometers an hour, and she's 26 years old. So is there anyone in this room that would image this patient right now based on a high-risk mechanism? If there is, would you please raise your hand? Okay. And we had previously defined the high-risk mechanisms, especially in relation to MBCs, as speeds greater than 100 kilometers an hour, rollovers, or ejections. But what if this patient was involved in a head-on collision and their car was going 60 kilometers an hour and the car they struck was going 40 kilometers an hour? Is there anyone that would now image this patient based on high-risk mechanism? Anyone who would raise your hand? So the Canadian C-spine rule doesn't really specify the speed component of high-risk mechanism, whether it's the solely determined by patient-propelled vehicle or whether it's a combined speed of both cars. So I don't really know what to do in this situation. I couldn't really find any great literature supporting one way or another. In the Canadian C-spine rule, it was powered to be sensitive to detect all cervical spine injuries that were considered important, but they did classify some injuries that they considered non-important. And unimportant injuries were the 4 listed above in neurologically intact patients. So if there was an isolated avulsion of an osteophyte, if they had a fracture of their transverse process not involving the facet joint, if they had an isolated fracture of the spinous process not involving the lamina, or if they had a simple compression fracture of the vertebrae involving less than 25% of the vertebral body, the rule wasn't developed to be sensitive to pick up these injuries. So when you're applying it, it's important to know that you may be missing injuries, but they're likely these clinically unimportant injuries that wouldn't change management. So the diagnostic accuracy of the Canadian C-spine rule, in its derivation study, its sensitivity was 100% and specificity of 42. And again, in the validation study published in New England Journal in 2003, the sensitivity was 99 and specificity 45. And the 95% confidence intervals are shown there. In 2012, in the Canadian Medical Association Journal, there's a study that did a systematic review comparing Nexus and Canadian C-spine rule, and they found the sensitivity to range from 90 to 100%, and the specificity to range from 1 to 77%. And those numbers don't look all that great, But when you look at the studies that they included in that systematic review, some of them use like a quasi Canadian C-spine rule where they didn't range of motion people at the end, so they weren't including the complete rule. So I'm not really sure how much judgment or how much importance I would place on that low sensitivity in the systematic review. So one of the things they wanted to do was decrease our imaging rates because we were imaging everyone. And in an Australian implementation study in 2005, this was a pretty rigid implementation study. In order to get a C-spine 3-view plain film, you had to fill out the Canadian C-spine rule on a computer-based document, and the radiology tech would not perform the imaging unless you did so. And with a strict implementation, they found that the X-ray ordering rates decreased from 67 to 50%, which was a 25% relative reduction. And they also found that time in hard color reduced from a median of 128 minutes to a median of 103. So what about Nexus? If you've read about C-spine injuries and you've read the Canadian C-spine rule, you've definitely heard about Nexus, and it's another clinical decision rule that was published by Hoffman in the New England Journal of Medicine in 2000. This rule states that cervical spine radiology is indicated for all patients with neck trauma unless they meet all the 4 following criteria. So no posterior midline cervical tenderness, no evidence of intoxication, they have to have a GCS of 15, they can't have any focal neurologic deficits, and they have no painful distracting injury. So why don't we use Nexus? The concern was initially in regards to its low specificity. Its specificity in the validation study was 12.9%. And when you applied this rule to the Canadian population, there was potentially implications of increasing the rates of imaging at our hospitals. There's a prospective cohort study that compared the Canadian C-spine rule to Nexus, and the Canadian C-spine rule proved higher in both sensitivity and specificity as listed on the slide. So that's basically all I wanted to touch on about the Canadian C-spine rule, given the title was Beyond the Canadian C-spine rule of my talk. So is there any burning questions or issues people wanted to raise before we move on in terms of using this clinical decision rule? Okay, let's go back to the case. So you've determined she doesn't have any high-risk mechanisms, but unfortunately she doesn't have any low-risk features, and she does have midline tenderness, so you're gonna have to get some imaging to clear this patient's cervical spine. So who in this room in favor of, the question is what imaging do you get to clear the cervical spine? Is it a CT or is it a 3-view plain film? So everyone in favor of a 3-view plain film, please raise your hand. Okay, and then everyone in favor of a CT? Okay. So MCRIT is a pretty popular podcast, and most people have either heard of it or listen to it regularly. It's published by Dr. Scott Weingart, who's an intensivist and emerge doc in New York. And this is a podcast that kind of got me thinking about how we clear cervical spines. I'm going to play a little clip from the podcast, and in this segment he's talking about how he goes about clearing people's spines with imaging who fail a combination of Nexus and the Canadian C-spine rule, essentially just range of motions everyone after applying Nexus. He basically emphatically states that we shouldn't be using X-rays and CT should be our primary imaging modality, stating that they miss injuries, they're more expensive, and they take longer. And he goes on to cite EAST. So EAST is the Eastern Association for Surgery of Trauma. And they publish a guidelines for identification of cervical spine injuries following trauma. It was first published in 1998, then in 2000, and again in 2009. And the version in 2009 is a consensus guideline based on 52 different trials. So their first recommendation is that in awake alert patients in trauma without neurologic deficit, who don't have any painful distracting injuries, have no neck tenderness, and have full range of motion, you don't have to get imaging, and we all know that. But it says for anyone else who you suspect a cervical spine injury for, you need to get imaging. And their recommendation is that primary screening modality is axial CT from occiput to T1 with sagittal and coronal reconstruction. And they also go on to say that plain radiographs contribute no additional information and should not be obtained. So in eMERGE, we're often caught in that battle between the surgeon and the radiologist and trying to figure out when to image and when not to image. So I wanted to see, and this is a surgical association, so I wanted to see what the radiologist had to say. So the American College of Radiology publishes and appropriateness criteria for suspected cervical or spine trauma, and this was published in 2012. They also concluded that thin section multi-dose CT and not radiography should be the primary screening imaging modality for suspected cervical spine injuries. But these are both two American associations, and we know our neighbors to the south of the border are a bit more liberal in their use of advanced imaging modalities, and we're a bit more conservative. So I wanted to see what our Canadian associations had to say. And when you look at the Canadian Association of Radiologists, they have a diagnostic imaging referral guideline, and this was published in 2012. For conscious patients with head injury and or facial injury, they basically say that that imaging is required for patients who do not meet the C-spine rule. But they go on to say that although X-ray is indicated in specific circumstances, basically patients who fail to meet the C-spine rule, due to the superior visualization of both bony and soft tissue injuries, CT should be obtained as the first-line modality if available. And they go on to say that X-rays of the cervical spine are only indicated if CT is not readily available. So, why should you care? Read your mind, Pringle. I knew you were going to be here. Okay? Okay. So why should you care? These are associations who have experts in their respective fields, and now we're trying to practice evidence-guided medicine, so these consensus guidelines are based on current literature reviews and expert opinions based on the literature review. I think they do contribute to the standard of care, and by that I think they have potential legal implications. So if you missed a cervical spine injury that was unstable and you had only cleared the patient using a 3-view plain film, I think there's now 3 organizations that someone could throw in your face saying CT should have been your primary imaging modality. So I think there is a reason to care about what they say, but I think you have to look into the literature yourself, and we're going to do that in a couple slides. The pros of plain films are it's pretty readily available. It doesn't usually take a long time to get those done in the department. There's a lower ionizing radiation dose. We're pretty comfortable with interpreting these images and looking at the X-rays ourselves. And then there's the issue of cost. When compared head-to-head, a 3-view plain film costs significantly less than a CT C-spine. And there was some cost analysis literature that was mainly out of the States and incorporated medical legal implications of having missed cervical spine injuries, and I found it a bit confusing, so I didn't want to go into that today. But the cons of plain radiographs are they can be frequently inadequate studies, so patient body habitus, positioning, overlying tubes and lines can really affect your ability to interpret the study as adequate or inadequate. And we're hearing that they're potentially insensitive, so do they miss injuries? That's a potential con. For CTs, they're a highly sensitive exam, as we're going to see. They have higher resolution imaging, so they're not the best soft tissue imaging modality, but they can provide a little bit more information to soft tissue injuries. And they're pretty reliable at producing adequate images. What about the cost? So the direct cost of the medical system is already brought up. The limited availability, so at nighttime we usually have 1 or 2 scanners going, and there's usually a list of people waiting to go through the scanner. So how long are you going to keep the patient in a cervical collar for while waiting for the CT? And potentially difficult to interpret. So we're more comfortable with plain films, and I'm not sure I'd be comfortable looking at a CT and clearing it based on my interpretation. I'm not sure how many staff would be willing to. And they have a higher dose of ionizing radiation. I'd emailed a couple people at our organization to find out the direct cost, and I didn't hear back, so I'm not entirely sure. Does anyone have some ballpark numbers? Okay. We can look into that and send it out. So what about the estimated radiation dose? So in Spine in 2010, Richards and his colleagues published a study that looked at the radiation dose comparing CT versus 3-view plain films. So for a 3-view plain film of the cervical spine, the estimated radiation dose is 0.1 MSV. And for the CT of occiput to T1, estimated radiation dose is 3.45. One thing that's important to consider is when you're imaging the C-spine, You have the thyroid gland that's sitting there, and it's one of the most sensitive organs to radiation-induced malignancies, with radiation exposure being the most clearly defined environmental factor associated with both malignant and benign tumors of the thyroid gland. They did an estimated risk of radiation-induced cancer in this study, and for 3-view plain films, estimated radiation-induced cancer was 1 in 200,000 scans to produce a malignancy. For CT, it was 1 in 5,800. So the way they came up with this estimation was a bit complicated and used some computer-based algorithms and to be honest, I didn't really understand all that much. And I don't know how accurate these numbers are, but what I took away from it is how staggering the difference is, 1 in 200,000 versus 1 in 5,800. So it's something to be aware of when you're considering the use of CT for cervical spine injuries in all patients presenting with blunt trauma. So let's look at some of the literature. In 2000, a study published in Radiology by Kane was a systematic review comparing plain films versus CT. They did an electronic search of Medline, Embase, all the usual suspects, and the search was from 2001 to 2008. Their PICO question was essentially this. The population was patients suspected of having sustained a cervical spine injury following a blunt trauma. Their diagnostic test was plain films. Their comparison diagnostic test was helical or multi-slice CT, and their outcome measure was the sensitivity and specificity for each of the diagnostic imaging studies. Their study design was a diagnostic study in which the results of plain radiography and CT were compared with the results of a reference standard. So their exclusion criteria are failure to include a minimum of 3 views, failure to perform a CT of the entire cervical spine, studies without direct comparison between CT and plain films, and review articles. So they identified 1,500 potential studies, and they excluded 1,487 due to relevance. With the remaining 8 studies, they were reviewed, and 8 were excluded due to the exclusion criteria that I listed in the previous slide. So they found 10 studies, and their patient populations in the 10 studies varied considerably. So in 3 studies, they were retrospectively selected patients diagnosed with cervical spine injury in which both plain films and CT were performed. In 4 studies, they selected only the most severely injured patients, so patients with altered mental status, patients requiring ICU admission, or high trauma patients, and the incidence of cervical spine injury in those 4 studies was 11 to 34%. In the studies published around Nexus and the Canadian C-spine rule, the estimated incidence of cervical spine injuries in blunt trauma patients was 2 to 4%. So obviously 11 to 34 is a huge jump from that number, and that's a result of selecting only the most severely injured patients. In the final 3 studies, they included patients from all risk groups, and they underwent both radiography of the cervical and CT of the cervical spine. So before we get into the results, I just want to talk about some of the potential biases or limitations of the systematic review that these authors identified. So the first one's selection bias. So when you're including patients in a study, the ideal patient population is all patients that meet inclusion criteria and none of the patients that meet exclusion criteria, and it's ideal if they can be enrolled consecutively. Only 2 of the studies in the systematic review used or stated that they had consecutive enrollment of patients over a time period. One of the studies used a convenience sample, and the other 7 studies did not state how they enrolled patients. So we're unsure how they were enrolling their patients in these 7 studies. So potentially open to selection bias. Incorporation bias is really interesting. So it essentially has to do with the gold standard and the reference standard for making a diagnosis of an injury. So when you're comparing 2 diagnostic tests, they should be separate from the gold standard in determining if the patient has the diagnosis you're questioning. So to make that a little simpler, in these studies, they use a composite of both CT and X-ray to make the final diagnosis of cervical spine injury, because we don't really have another study to diagnose imaging, and they didn't follow up patients. So the use of CT as the final say as to whether a person has a cervical spine injury limits these studies, as they likely have some incorporation bias. And this is likely significant because it probably overestimates the sensitivity of CT. If CT is the final say, then you're not really going to have any missed injuries with CT. And then finally, review bias. So whether the people interpreting images were blinded. And in 3 of the studies, it clearly states that the interpreters were blinded to the reviews of the other study. In one study, they used partial blinding, where CT was always interpreted first prior to plain films, regardless of, or was always interpreted first. And that potentially, I mean, the way that's going to affect things is it's probably going to increase the sensitivity of your plain films, because if you review your CTs first and you pick up an injury, you're going to know what to look for on the plain films. So it may have overestimated the sensitivity of plain films. And in the remaining 6 studies, the interpreters were neither blinded or blinding was not discussed or reported. So what did they find in the systematic review? So the sensitivities for CT range from 90 to 100%. And for plain films, they range from 38 to 93%. They're listed here. Only one study, you can't see my marker, had a sensitivity of plain films that even approached that of CT. The rest are pretty staggering differences. For specificity, CT ranged from 98 to 100%, and the specificity ranged from 95 to 100%. 3 of the studies only included patients with diagnosed cervical spine injury, so you couldn't really calculate a specificity in those studies. So are we ready to say that plain films and blunt trauma patients are going the way of the dodo and we're going to be screening everyone with CTs? I'm not so sure, and neither are the authors of the study. So in this study, they were essentially dealing with 2 different patient populations, and they were different based on their pretest probability of a cervical spine injury. You had your high-risk patients, high energy, low GCS requiring ICU admission. Then you had your low-risk patients. So the patients that we're really interested in, the alert, the sober, those that don't have any paresthesias, but you're unable to clear them based on the C-spine rule. So in the cited studies in this systematic review, they showed that in the high-risk patients, plain films were frequently inadequate to study the cervical spine. In 52% of high-risk patients, plain films didn't cut it. And that was usually due to patient positioning, overlying artifacts from tubes and lines, and getting adequate odontoid views. How do you get an odontoid view in someone who's obtunded? It's going to be pretty hard to get them to open their mouth to get that view. They also found that even in technically adequate studies, plain films can be falsely negative, and they had a sensitivity of 52% in technically adequate studies. So essentially, don't waste your time ordering plain films in high-risk patients. And I don't think that's news to anybody. I think that's everyone's practice. If somebody's obtunded or going to the unit, they're probably getting a CT head to begin with, and I think the practice pattern that I've been exposed to is to continue with the CT C-spine. But what about patients who weren't high risk? So this is one of the studies that were included in the systematic review, published in the Journal of Trauma in 2007. So it was a prospective study. They enrolled all patients presenting to the ED, and patients who could not be cleared by the Nexus criteria were enrolled, and they had a CT and plain film ordered. 27 of 60 injuries were clinically significant, and 15 of those clinically significant injuries had positive CTs and negative plain films. And in this study, the sensitivity was around 50%. For the patients that needed surgery in the group who had negative plain films and had a positive CT, these are the injuries. So they're pretty significant injuries, and they're ones you don't want to miss. So even in studies that included all patients, not just the high risks, CT continued to outperform plain films, and it was by a long shot. They weren't even close. And plain films were still missing clinically important injuries. But when you look at the 3 studies that included all patients, you see that the incidence of cervical spine injury was still much higher than what we know it to be, and it was 6.8 to 9.5% versus the 2 to 4 as previously defined. And if you look at the average GCS in these studies, it was around 12. So you still have extremely high-risk patients who we would never include in the Canadian C-spine rule to rule out cervical spine injuries. So how you use this information to help you in the low-risk patients, I'm still not sure. The authors then pointed to the data from the initial Nexus study. So they did a secondary analysis of their data, and they wanted to compare CT versus X-ray. So just for the Nexus study, they included all blunt trauma patients who had a 3-view plain film in their study, and they supplemented the plain film with advanced imaging when deemed necessary by their authors, or by the practicing physician. So they didn't do a CT for every patient that came in. They identified cervical spine injury in 818 of the 34,000 patients with an incidence of 2.4, and plain films miss 320 of these patients with injury. The majority of these misses were due to inadequate studies, and all injuries were picked up on secondary imaging in the emergency department. Adequate plain films missed 23 injuries, or 0.07% of patients enrolled, and 3 of these misses were potentially unstable. So that looks pretty good in support of plain films for assessing for cervical spine injury. But it's important to realize that injuries may have been missed because order study physicians may have stopped imaging after having a plain film, and we don't really know what happened to those patients who had normal plain films and were discharged from the emerge. There wasn't any follow-up in the Nexus study itself. The study authors in the secondary study went and reviewed neurosurgical and risk management logs for all participating studies for 3 months after the study date ended. But these studies were performed in major U.S. academic centers and big cities where there's multiple hospitals. So I don't think you can definitively say that no cervical spine injuries are missed in normal plain films when patients were sent home from the emerge. So the conclusion that Kane came to is that you need to base your imaging for cervical spine injuries based on pretest probability. In patients who are at high risk, you need to get a cervical CT, and that's not news to anybody here. They go on to state in patients at low risk of cervical spine injury, a good quality plain radiography is sufficient. That's based on Nexus data. So I believe the conclusion I've come to here, I came to a very similar conclusion. But I think I would state is likely sufficient. I think we have the data. I don't think there are any in low-risk patients that really help us definitively say it's sufficient in cervical spine injury. So that was sort of my spiel on CT versus X-ray. I'm not sure if any of the staff wanted to comment on what their practice is, or what, I mean, Dr. Pringle, if you wanted, you can.
Well, you didn't say anything. I thought you were going to go crazy, but you didn't go crazy. And I think, your conclusions are kind of right. I think, when you listen to people talk about the Nexus study, and the Nexus, and the Nexus dwarfs all other studies. It's just, 35 over 1,400 fractures. And so that's really the big piece of data. And yes, when you look at that, it's in the numbers. It's only 90% sensitive, or 92% sensitive. But when you look at the misses were that the films were inadequate. So the films weren't done properly. 2, the physician did it on some little old lady who's 95 and fell down, and they just say, well, I can't tell. So they go on to a further study. Or they pick up one fracture, so then they go on to a CT, and then they pick up a second fracture. Or on the CT, they pick up a clinically insignificant fracture. And that takes away, that moves the sensitivity up to like 99%. And they really only had 3 true misses, okay, in people that had adequate films done, had everything done appropriately. And those were clinically obvious. The patient, as you guys all know, when people break bones, it hurts, and it hurts a lot. And I think most of the staff here would agree that, when you see someone with a broken neck, for the most part, it's not rocket science. It hurts like hell. And it's not some weird thing that, oh my God, they had absolutely no pain, they had no nothing, and they had this massive fracture that was totally unstable. I don't think any of the staff, I'm talking about, for the last 20 years we've done plain films. Can any of the staff here say that they've seen a plain film that they've done, sent the patient home, and then they've come back with some clinically unstable massive fracture, or came back paralyzed? I haven't heard of any, and I don't know if anybody else has heard of any, but so I think yes, the person whose GCS is low, the old person who, I don't care if you radiate the crap out of some 90-year-old lady, go ahead. If you can't tell, if you get inadequate film, if they're GCS, yeah, they're going to the ICU and you're doing 10 other scans, for sure go ahead and do the scan. But that's not the people that we're dealing with for the most part. It's young people who are in fender benders or fell off their bicycle, who I think in our, we just can't miss anything. We're so worried about those errors of omission that we do these, I can see it, that people start doing these CTs like crazy, and we will hurt people down the road. We will cause cancers down the road, and I just don't think that's right, that we cover our ass and lead to problems down the road because you're just looking to cover your ass.
I agree, and I think this literature should show you that when you look at EAST guidelines and the American College of Radiology guidelines, the recommendations are founded on high-risk patients, and they're using that data to make recommendations for all patients with suspected cervical spine injury. So I think you're justified in not CTing every low-risk patient, even though EAST and the American College of Radiology says you should, or suggests you should. And I think that was what I wanted to really drive home, in that you really have to look at the literature and what guidelines are using to support their claims.
Two questions that kind of meld into one. Did you find any reason why London does not use the 3 C-spine film rule and uses 5, shoots 2 obliques for every C-spine series? And added on to that, any more recent literature about flexion extension views, and why London, if they're going to insist on shooting 5 films, they don't can the obliques that don't give as much, and shoot proper flex X films, which may pick up unstable ligamentous injuries?
So we're going to talk about the second part of that question in the next part of the talk. But in terms of why we use 5 versus 3, I'm not entirely sure. I don't know. I don't know if anyone can comment on that.
It's a neurosurgical thing. That's all I can tell you. That because even when I was in Toronto doing some neurosurgery there, they only shot 3, and I came back and asked here, and at least at University Hospital, the radiology department at the time was driven by the neurosurgical requests. But the neurosurgeons who drove that are no longer here, so I'm not sure if that's still the case or it's just kind of left over from that and nobody's bothered to question it, and that's why it still is. But
so you had recently listened to Dr. Weingart's podcast, and you got a CT of this patient's C-spine because you thought X-rays were not good in low-risk patients, and she had a normal CT of her C-spine. And you had given her some analgesia with some Toradol and Tylenol, maybe a whiff of morphine. But she's stating that when you palpate her cervical spine after the normal CT, she has persistent, recreatable C-spine tenderness at C5 to C6 that has not changed in severity whatsoever. You still have her in the call, or you haven't range of motion to her. So Doran, what are your thoughts right now, and what else could be going on in this patient? And are you comfortable clearing her C-spine with that persistent tenderness?
Well, the CT is good at looking at the structures, not good at looking into the soft tissue.
Okay.
So she could have like hematoma, she could have edema, she could have a ruptured disc, she could have all kinds of other things that are going on.
Okay.
In which case, if you're suspicious that there's persistent injury, you might want to look at going on to an MRI.
Okay. Perfect. So what do we do with patients with persistent midline tenderness after a negative CT? So those with neurologic findings, people who have persistent paresthesias and the CT is normal, the answer is pretty obvious. You're going to have to get some further imaging to figure out why they're having that persistent paresthesia. In the obtunded patient, in the emerge, we're not really dealing with that. If someone's obtunded, they're obviously not going out the door, and they're usually going to the ICU, who has their own protocols on clearing patients with for cervical spine injury after blunt trauma. And that's a bit beyond the talk that I wanted to go into today in terms of what they do in the ICU. But in otherwise intact CT-negative patients with persistent midline tenderness, the management's a bit unclear. So EAST suggests one of 3 options: flexion extension plain films, cervical collar with appropriate follow-up, or an MRI. So I was just curious what our current group's practice is in terms of this patient population. What are people doing right now for patients who have persistent midline tenderness after normal CT?
Sorry, was we expecting the CT to cure that midline neck pain? Like, I mean, most of the time, people fail Nexus because they have midline bony tenderness, correct? So I'm just not sure how you would think that that's going to go away after your CT. Is that really what we're asking?
If they're neurologically normal, I take the collar off and send them home.
Yeah, if there's not a problem.
Do you range of motion then once you get rid of the collar?
Well, just rotate your neck if you don't get neurologic symptoms.
Okay.
There is a significant population of patients who complain. You end up in CT and it's negative. You tell them it's negative, they jump off the bed, right? There is that group, but what he's talking about more is the group that you tell them it's negative and they're like, I can't move it. It hurts. That's more what he's looking at in this case here.
Or the patient who you come back 5 times and every single time they have severe pain at a specific cervical level. And you're thinking, why are you having pain there every single time? It's not diffuse pain, it's localized, but they have no neurologic injuries. Are you worried at that point? Or is anybody keeping them in a collar and sending them for outpatient follow-up? Or is everyone just clearing them at that point with a negative CT?
I think that's a really unusual, at least in my practice, that's a pretty unusual clinical scenario. Yes, it's like Grant said, you use your clinical judgment. If you really have concerns, yeah, obviously if there's any neurological paresthesias or weakness or numbness, you're putting the collar on, you're doing an MRI. But those are pretty exceedingly rare injuries. And that scenario, I think, is pretty unusual.
Okay. So just wanted to go over these 3 suggestions. So in terms of the flexion extension plain films, when you look at what the American College of Radiology says flexion extension views often add little clinical value in the acute setting, and that's because of secondary muscle spasm around the injury. In terms of sending them home with appropriate follow-up in a cervical collar, there's some potential negative effects of keeping someone in a cervical collar for a prolonged period of time, a week or 2. First is patient discomfort. It's not comfortable being in a cervical collar. Second is anxiety. You're sending them home saying, I think you're clear, but I'm going to keep you in the collar and have you followed up to make sure you don't have an unstable injury. Patients are probably going to have a loss of income as they're not going to work unless they're lucky enough to have the injury occur at work and they're claiming WSIB. And you have to arrange follow-up for the patient, so that's provider and patient time. What about MRI? So like Sean said, what about ordering an MRI for this patient? So there's no randomized control trial that compares CT negative patients followed by MRI to CT and sending them on their way. And the current literature for MRI after a negative CT really focuses on the obtunded patient in the ICU. I was able to find one study that was published in 2011 in the Annals of Emergency Medicine, and it was a prospective cohort study. They included patients who were alert GCS 15, who met Nexus criteria for assessing their cervical spine injury, that had a normal CT but persistent midline tenderness after their normal CT. Their exclusion criteria were a fracture of the skull or base of the skull or upper thoracic spine fracture, a painful distracting injury or evidence of intoxication, persistent focal neurologic deficits, or history of cervical spine injury, and the MRI had to be performed within 96 hours of presentation. Interestingly, patients who had transient neurologic deficits that resolved prior to the MRI were included in this study, and both CT and MRIs were reviewed by 2 different radiologists, but they were unblinded. So they identified 741 patients who had normal CTs with persistent midline tenderness. 554 were excluded due to the exclusion criteria I just talked about. 9 failed to consent, and they included 178. So of those 178 patients, they found 78 acute cervical spine injuries detected on MRI. 40 of those injuries were deemed non-clinically significant, and the collar was discontinued and the patient was managed with symptomatic control. For the remaining 36 patients, 5 needed operative management of a cervical spine injury, and 33 had prolonged cervical mobilization to manage their injury. And the operative procedure for those 5 patients was an anterior cervical discectomy and fusion. So they did a logistic regression to identify patients to figure out what features were consistent with a higher number of C-spine columns injured and a positive MRI. So we know that as you have higher higher number of columns injured in your cervical spine, the potential for instability and requirement for management increases. So they found that advanced CT detected cervical degenerative changes had an odds ratio of 11.6. For minor isolated thoracic lumbar fractures, the odds ratio was 5.4. And for a multi-directional cervical spine force in the injury, the odds ratio was 2.5. So the authors of this study noted that their institution changed their cervical spine clearance from MRIing all patients with persistent midline tenderness to MRIing only patients with the 3 features listed below. Yeah, and that's all I was going to talk about for MRI post-CT, not negative CT. So I think you have to be cognitive of the fact that you may have a cervical spine fracture or a cervical spine injury in someone who has a normal CT, and you have to at least think about ligamentous injury in patients who have some persistent paresthesias or midline tenderness after normal CT. Maybe these 3 factors are the factors that make you think, I should probably move on to MRI or keep them in a collar until they can be reassessed. Interestingly, all MRIs in the study had to be performed within 96 hours, and I'm not sure the logistics of how frequently we're going to get our patients in within 96 hours for an MRI. The reason they chose 96 hours was they found that findings on MRI like edema or hyperemia had decreased significantly after the 96 hours, and they required those to really identify the ligamentous injuries. So to conclude my talk, just wanted a couple drive home points. So for the Canadian C-spine rules, you got to know who to use the rule in, you got to know who not to use the rule with, and you got to know how to use the rule correctly. For high-risk patients with suspected cervical spine injury, CT is the way to go, and we all know that. For low-risk patients, adequate plain films are likely adequate, but I'm not sure we have definitive literature stating that. And in CT versus MRI, oh, this is CT. Sorry, I mistyped. For patients, when to suspect ligamentous injury, patients with persistent neurologic deficits despite a normal CT, and patients with persistent recreatable midline tenderness and high-risk patients, so patients with degenerative changes on their CT, those with associated thoracic or lumbar fractures, or those having suffered a multi-directional force injury. Thanks for your time and your attention.